Welcome to This Explainer. Today, we're going to completely decode the medical complexities of hypothyroidism. We are tracing the entire clinical journey, literally from the very root causes all the way to life-threatening emergencies. It's a fascinating ride, so let's get right into it. Okay, so here's our roadmap for today. We'll be hitting 1. The root causes. 2. Hashimoto's and autoimmunity. 3. Spotting the symptoms. 4. Diagnosis and labs. 5. Treatment and special cases. And finally, 6. The myxedema coma emergency. Section 1. The root causes. We have to start our journey by looking at the very origins of a failing thyroid gland. It's actually wild how much geography changes the pathology of this disease. See, while a huge portion of the globe struggles with iodine deficiency, which leads to those endemic goiters you might have learned about, developed nations with iodine-sufficient diets face a totally different threat. Here, the primary culprits shift almost entirely to autoimmune destruction, mainly Hashimoto's, and iatrogenic, or medically induced triggers like radioiodine therapy and NEC radiation. Now, looking at newborns, congenital hypothyroidism affects roughly 1 in 2 to 4,000 infants. And this data is super important because it shows that 65% of these congenital cases stem from dysgenesis, which is just a developmental abnormality of the gland itself. Another 30% are due to dyshormonal genesis. The really tricky part? Most of these infants appear completely normal at birth. That is why early heel prick screening is absolutely critical. We have to catch this early to prevent permanent neurological damage. Section 2, Hashimoto's and autoimmunity. Let's zoom in on the most common cause in the developed world. So the crucial takeaway here is that while the actual onset of the disease often begins between the ages of 30 and 50, the mean age of an actual clinical diagnosis is 60 years old. Think about that for a second. This means patients are very often living with a slowly failing gland, dealing with subtle, nagging symptoms for literal decades before it's officially caught by a doctor. What's truly revealing here is how the gland is actually destroyed. We hear a ton about TPO antibodies, right? And yes, they are present in over 95% of patients, but guess what? Those are mostly just clinical markers. The primary attackers that are actually doing the heavy lifting and destroying the tissue are CD8+ cytotoxic T cells. Direct T-cell injury is absolutely required to kick off the destruction. We also see some really strong genetic ties to HLA-DR3, 4, and 5, plus a frequent association with other autoimmune conditions like type 1 diabetes and Addison's disease, creating what we call autoimmune polyendocrine syndrome type 2. Section 3, spotting the symptoms. As the gland starts to fail, we see a really wide and honestly sometimes confusing array of physical symptoms. This definition is so vital because myxedema is definitely not your typical swelling. It is a unique molecular water trap right in the skin because dermal glycoaminoglycans are literally holding on to the water molecules. It presents as non-pitting edema. That means if you press on the swollen skin, it doesn't leave an indentation like simple fluid retention does. It just bounces right back. Okay, let's bust a major myth right now. The weight gain these patients experience, it's mostly just this trapped fluid we just talked about, rather than massive fat accumulation. And generally speaking, that weight gain is actually quite modest. Section 4, Diagnosis and Labs. So, how do we definitively prove this is happening in the blood? This logical step-by-step pathway highlights exactly how we diagnose the condition. First up, you measure TSH. A normal TSH generally excludes primary hypothyroidism right off the bat. But if it's elevated, you move to step 2 and measure free T4. A low free T4 confirms overt clinical hypothyroidism, while a normal free T4 points to subclinical hypothyroidism. But notice what's totally missing here? T3. Relying on T3 is a huge mistake because adaptive responses in the body actually keep T3 completely normal in about a quarter of hypothyroid patients. Now, notice how central or secondary hyperthyroidism totally breaks the rules. In primary hypothyroidism, the failing gland causes TSH to skyrocket. But in central hypothyroidism, which is caused by pituitary or hypothalamic disease, the TSH is completely unreliable. Why? Because it's immunoreactive but biologically inactive. You could literally have a low, normal, or even slightly elevated TSH alongside a low free T4. It's tricky. Section 5, Treatment and Special Cases. Treatment seems super simple on the surface, just give levothyroxine or LT4, but the clinical nuances are actually fascinating. If you really want to understand drug interactions, keep these two mnemonics in your back pocket: cafe bars and layer. Cafe bars shows us exactly what increases LT4 requirements by blocking its absorption. We're talking things like celiac disease and acids, iron supplements, estrogen, and PPIs. This is exactly why LT4 absolutely must be taken on an empty stomach. On the flip side, the layer mnemonic lists drugs that directly induce hypothyroidism, like lithium, amiodarone, interferon alpha, and immune checkpoint inhibitors. Now, pregnancy completely shifts the baseline. It requires immediate medication increases to protect fetal neural development. The preconception TSH goal is tightly controlled at under 2.5. And as soon as pregnancy is confirmed, we immediately increase the LT4 dose to 9 doses a week. So they're essentially taking 2 extra pills a week. For athyroidic women, meaning those without any functional thyroid tissue at all, they require roughly 45% more LT4. And remember those drug interactions we just covered? You have to separate prenatal vitamins and iron from the LT4 ingestion to ensure it actually gets absorbed. So what about when you see a massive medication dose, like 200 micrograms or more a day, but the patient's labs still look terrible? Well, the culprit is almost always poor adherence, not some kind of physiological resistance. A patient might take their medication for a few days right before a test, which quickly normalizes their T4, sure, but their TSH stays elevated because it actually takes weeks for the pituitary to adjust. But what happens if severe hypothyroidism goes completely untreated for a long time? Let's see how this builds to the most terrifying extreme of our clinical journey. Section 6. Myxedema Coma Emergency. We have arrived at myxedema coma, a profound, life-threatening medical emergency that strikes primarily in the elderly. The sheer gravity of this condition is captured in this staggering mortality rate, 20 to 40%. It remains this incredibly high despite intensive clinical care in the ICU, and surprisingly, it's independent of the patient's actual T4 and TSH levels. These spaced calm triggers, especially pneumonia, other infections, and severe cold exposure, are exactly what tip a severely hypothyroid patient over the edge into a coma. In fact, cold exposure can drop a patient's core body temperature as low as 23 degrees Celsius or about 74 degrees Fahrenheit. Add in sedatives, heart failure, a stroke, or just long-term low medication compliance, and you have an absolute perfect storm. Now, here is a critical warning for the medical detectives treating this. Aggressively warming these patients with external heaters when their temperature is above 30 degrees Celsius can actually trigger a fatal cardiovascular collapse. I know it sounds counterintuitive. You use space blankets to prevent further heat loss? Absolutely. But you must let the internal metabolism do the actual warming once the medications are given. This aggressive algorithm relies on a massive simultaneous strike. You're using both thyroid hormones and mandatory hydrocortisone. You give an IV loading dose of LT4 and an IV loading dose of T3 to instantly jumpstart the system. But here is the key to the whole thing. You must give IV hydrocortisone to prevent an adrenal crisis, because profound hypothyroidism severely impairs the body's adrenal reserve. Pair this with supportive care like ventilators and hypertonic saline, and you finally give the patient a fighting chance. As we wrap up this explainer, I just want you to consider how deeply this single butterfly-shaped gland impacts our bodies. From our skin and weight to our heart and brain, it literally controls so much of your body's engine. So ask yourself, what else might be hiding in plain sight? Thanks for joining me, and I'll see you next time.